Hi, everybody. This is Dr. Brett Talley Daniel, MD, neurologist and headache doctor. And today I'm talking about really one of the basic podcasts I should get out there quickly, but I haven't done yet, which is acute treatment of migraine headache. So how do you treat it? Migraine headache occurs in 12% of the American population. 25% of women and 6% of men have migraine headache. Migraine headache is the 5th most common cause of disability and the 10th most common cause of a visit to the emergency room. The 3 most painful conditions known are migraine, a kidney stone, and childbirth. So how do you give acute treatment of migraine headache? Migraine headache should be treated at the onset of headache pain with a triptan. Migraine headaches have 4 phases. There's a prodrome, an aura, the attack, and the postdrome. Migraine patients should treat either at the prodrome or the onset of the aura or the onset of an attack. And triptans work for about 80% of persons with migraine, but triptan non-responders may be treated with ergotamine drugs, which is old-timey treatment like ergotamine, Cafergot, or dihydrogamine drugs like Migranol. Newer drugs like Rayval also may be tried, but they're new and we don't know what they're going to be like in large clinical trials. So the prodrome may come 24 hours before the attack occurs. It may consist of fatigue, drowsiness, food cravings, depression, irritability, trouble concentrating, phonophobia, and increased urination or diarrhea. If these symptoms can be recognized by the patient as common and reliable occurring symptoms before the attack occurs, then the patient should treat before headache occurs at prodrome with a triptan. If a migraine with R patient has a visual R before the headache starts, then the patient should treat at the beginning of the R with a triptan. Migraine visual R's usually last 20 to 30 minutes, sometimes can last as long as an hour before the headache follows. Sometimes the headache may come before the aura, during the aura, or at the end of the aura. Treating at prodrome or aura means that treatment is early and the drug use is more likely to succeed. The problem is that some patients have their aura at the same time the headache starts, and these patients should treat at the onset of their aura if it comes at the same time they start with the headache. Some patients have their aura near the end of the headache attack, but they should have treated at the beginning of the headache. Only migraine headache patients have the altered brain neurophysiology that leads to headaches, so that 94% of men and 75% of women who don't have migraine don't have these physiologic changes. Only migraine patients do this. The migraine process releases 3 different neuropeptides. These chemicals cause arterial dilatation and inflammation of the trigeminal nerve, the arteries, and the thalamus. Triptans, if taken early, will stop this stage of the migraine process. Over-the-counter drugs don't do this. That's why triptans, which came out in 1991 as injectable Imitrex, subcutaneous 6 milligrams, have been so successful and important for treating migraine all over the world. It can be said that 80% of persons who treat their migraine at the onset, outlined as above, may be headache-free in about 2 hours. Comments regarding the available triptans. Triptans are not supposed to be used with a strong personal or family history of coronary artery disease, uncontrolled hypertension, patients who've had previous TI, stroke, or angina or coronary problems. Their triptans have some possible side effects, which are dose-related and can sometimes be ameliorated by dropping the dose. They cause chest tightness or pressure, near fainting, neck and back pain, which may be burning, a warm, hot dizziness feeling, or drowsiness. Now, not to go over all the dose and listing of the different triptans, but this is available on my webpage at drmigraine.com under categories, and then go to acute migraine therapy. I have an article there on that. Next, I want to talk about what's called the migraine timing cycle. There are 4 steps in the migraine process, which I like to call the migraine timing cycle. The first step is trigeminal inflammation by the brainstem. Then the second step, at 20-40 minutes, the ganglia, the nerve, and the artery in the brain start to release these neuropeptides, neurokinin A, substance P, and CGRP. Then at about 2 hours, the release of these chemicals causes the third step, which is meningeal artery vasodilatation. And the 4th step, at 3 to 4 hours, inflammation of the thalamus, which is a deep nucleus in the center of the brain. It's also called the pain center of the brain. The 4th step causes what's called in neurology talk central sensitizations, because steps 1, 2, and 3 occur in the skull but are outside the brain, that is the trigeminal nerve, the artery, the ganglion. But step 4, it inflames the actual part of the brain, the thalamus, the deep nucleus in the brain. Migraine is defined by the International Classification of Headaches lasting 4 to 72 hours, and that's not done for some trivial, abstract academic reason using 3 days or 72 hours as the time a migraine may last, but rather because that's how long these inflammatory neuropeptides stay in their body. They come into the brain, they down the veins to the liver, and they're discharged in the toilet after 3 days. If one treats migraine with over-the-counter drugs like Advil or Tylenol, they don't stop the release of neuropeptides and inflammation. Yet triptans will do that, and that's why they're so important and effective drugs for treating migraine. Patients with migraine should treat with triptans, but never with opiate drugs or drugs with butalbital like Fioricet. Butalbital is a barbituric drug and is, in my opinion, the worst drug in the world. It causes medication overuse headache, and it has been banned in every country in the world except Canada and the United States. The use of this drug in America is a political issue to be resolved by legislators, and so far neurologists and headache doctors have not been successful in eliminating the use of it. Caffeine, Tylenol, Advil, Aleve, and triptans can cause medication-induced headache if taken too much. The general rule of migraine patients to prevent medication-induced headaches is to limit over-the-counter painkillers and triptans to no more than 2 days a week. Medication-induced headache is the current term for patients who have chronic migraine from overuse of medication. It used to be called rebound headache, which is an old term. Chronic migraine is defined by the International Classification of Headache as being 15 headache days or more per month, 8 of which have migraine features, and episodic migraine is defined as 14 or less headache days per month. Now, if the patient uses over-the-counter medicines or a triptan, a transition occurs so that after several migraine headaches have occurred within a week or 2, every time the patient takes caffeine or Tylenol or a triptan, the inflammatory neurochemicals release and they stay in the body for 3 more days, and so the migraine process becomes continuous. It's sort of like putting lighter fluid on a fire, which makes the fire continue to burn. If one considers that migraine can generate chemicals that last 3 days and multiply that by 2 days, then the result would be 6 days of neurochemical release. So if the doctor allowed patients to take Tylenol or triptans 3 days a week, then that's 9 days of chemical inflammation, more than 7 days a week, and explains the limitation of why doctors say you can't use painkillers or triptans no more than 2 days a week. I have a more thorough discussion of the migraine timing cycle with pictures on my webpage at www.drmigraine.com, so check it out. You go categories, the general migraine to find the picture and discussion. However, the timing cycle points to the reason why migraine should be treated early with a triptan. The patient usually only has 20 to 40 minutes after the onset of pain before the neurochemicals are released, and a triptan drug will block the release of these chemicals. It's just that simple. Most patients don't know to treat early, and therefore the chemicals are released and inflame the trigeminal nerve, the arteries, and the thalamus. The patient returns and come back to the office and say, well, this triptan doesn't work. It's reported that triptans will help migraine headaches anytime during a migraine, even if it's treated late, but unless migraine is treated at onset, the patient will not be headache-free within 2 hours. Headache-free means that all migraine symptoms are gone: headache and nausea, sound sensitivity, light sensitivity, odor sensitivity, mental cloudiness. In my office, I go over and over this with patients, treat early, and then the next time they come in, they report they did well with the triptan, the migraine was gone early. Many patients tell me they'll get relief within 15 or 30 minutes, which is usually less than the reported time it takes the drug to work, as published by the FDA. So related questions regarding acute migraine therapy. Why don't patients treat their migraine early with a triptan? Well, number 1, hoarding. Patients only get a limited supply of drugs every month. Many times they get 9, or sometimes they'll get 3 a month or 3 a week or something like that, and they don't want to run out. They'll say, I've got to save them. It's the end of the month. I've only got 1 Maxalt left. Insurance companies limit sumatriptan 100 milligrams to only 9 a month. And some insurance companies only give 2 triptans per week. And if I write 10 per month, the patient has to go back to the drugstore every week to get the prescription filled. One study found that 37% of patients with insurance plans that limited the number of triptans per month didn't treat with their triptan at the onset of migraine and had more ER visits for headache per year than patients without insurance, who are more likely to take their medicine at the onset of the headache. Another reason why patients don't treat: expense. With insurance, there's now a copay of $10 to $40 per prescription, which can add up if the patient's taken several drugs. However, all of the triptans now are generic and cheaper than name brand. And sometimes you can find coupons online that are a better deal than using a drug insurance plan. What's another reason why triptans don't work? Nihilism. The patient will think nothing works. Many migraine patients have ingrained previous experience that nothing will work. These are migraine patients who've been using over-the-counter meds, opiate narcotics, or butalbital for years, and have developed medication overuse headache. And triptans just don't work in that situation. Nothing works in that situation except DHE. And you got to see my article on the webpage at Medication Overuse Headache. What is it? So its category is medication overuse headache. Cursing down to the frowny face made of pills near the bottom, and read the article there I've got on that subject. This group of patients with low expectations that anything will ever work includes migraine patients who have been prescribed triptans but were never instructed to treat at onset and when the headache's early and mild. When these episodic migraine patients finally do try their triptan early, the same drug they've always waited to use, they're pleasantly surprised with how well the drug works. They come back for their neurology recheck and visit with a smile on their faces. They just never knew how to treat their migraine. Another thing is why people don't take triptans. There's fear of overtreatment. The patient will say, I don't want to take too much medicine. Experienced migraine patients know that if they take too much medicine, it may, like a snake on the ground that you try to bash on the head, rise up and bite you on the leg, resulting in more headaches. And generally, one is only supposed to treat headache 2 days a week. As I've said previously, this 2 days a week treatment rule is true for coffee, over-the-counter NSAIDs, opiates, and triptans. Only one of the triptans, rizatriptan, is the only one that you can give 3 doses a day in 24 hours. All of the other triptans are limited to 2 tablets a day. Lawrence Newman, director of a Headache Institute at St. Luke's Roosevelt Hospital Center in New York, speaking in an interview with Primary Neuro Reviews in 2007, was asked the following questions. If you had a single piece of advice you could give to every healthcare professional treating patients with episodic migraines to ensure that fewer of their patients with migraine would progress to chronic daily headache, what would it be? Newman's response was to limit the number of acute medications they are giving at one time, not to be liberal with refills, so that you keep a close watch on how many medications patients are using and initiate a preventive treatment in appropriate patients. If you do that, you can proactively, in many patients, prevent medication overuse headache and the progression of the disorder. Okay, what's another reason why patients don't treat early? There's a concern for side effects. The triptan will treat the headache, but the patient dreads the side effects, the chest tightness, the pressure, near fainting, back and neck pain, burning, hotness, all that stuff. This is where the treating doctor should explain that triptan side effects are not serious. Many patients hearing this will gladly tolerate a mild side effect for a miraculous drug that treats a dadgum migraine. These patients should be instructed that triptan side effects are dose-related, and sometimes merely decreasing the dose, like going from 100 milligrams sumatriptan to 50, may avoid the side effect. If that doesn't work, then the patient is due for a trial of a different triptan. There are 5 acute onset drugs which work in 30 minutes, and these drugs are oral sumatriptan, rizatriptan, zomatriptan, elatriptan, and almatriptan. All right, which is the best triptan? That's something known for a long period of time. But finally, the American Academy of Neurology several years ago published their results saying the best triptan overall was the first way the drug came out in 91, which is injectable subcutaneous 6 milligrams sumatriptan, just like Glaxol brought it out in 1991 as the first triptan. All right, what's the other reasons patients don't do well? They wait. They'll say, I just wanted to wait and see if it would go away. I wasn't sure it was migraine. Sometimes they just go away on their own. I was waiting to see if it was going to be one of those, and It usually is. This is the old, I want to wait to see what happens with a headache game of Russian roulette patients play, which is unproductive and usually self-defeating. They wait and they lose. Again, about 80% of patients can be headache-free if they treat at onset. Deloff and Mellberg from the Gothenburg Migraine Clinic in Sweden were quoted in neurology reviews in 2007 as finding a substantial difference in total pain in early versus late treatment with triptans. They found the difference was greatest with oral triptan treatment as compared with injections and nasal spray. And early treatment had a quote-unquote substantial impact, end quote, on pain, aura, nausea, photophobia, and phonophobia. These authors stated, quote, overall, the total pain during the 72-hour follow-up period was lower after early treatment. Pain intensity scores at 0, 1, and 2 hours after treatment were also dependent on time of treatment administration. All right, another reason why patients don't use these drugs. Well, they ignore nighttime migraines. I woke up at 4 in the morning with a headache. What could you do? I just rolled over and went back to sleep, but I had a terrible wake-up headache in the morning. This is the nocturnal migraine that comes at the end of a rapid eye movement event. Many patients with headache like this wake up in the morning with the migraine still there 2 or 3 hours later. They are already at stage 4 of the migraine process in central sensitization. The triptans don't work as well then. These early morning migraines last all day and sometimes the next. These patients should be instructed to sleep with their triptan pill open and available on the table with a glass of water next to their bed so they can sit up, take their medicine, and go back to sleep, with probably not even getting out of bed. Also, injectable sumatriptan or intracranial sumatriptan or zolmitriptan may help nocturnal headaches because they work in about 10 minutes as opposed to 30 minutes for the other acute onset triptans. This is how to treat nighttime headache at onset when early and mild. And the last thing I've got listed here is the reason why people don't use the drugs are excuses. I will hear as a doctor. I was at work. I left my medicine home. I was in the middle of an important meeting. I was driving to work in traffic. It rained and the freeway backed up. I had a deadline to get a project finished that day, and I couldn't do anything else. I couldn't eat lunch. My dog ate my medication, term project, homework. That's a joke. These are patients who haven't faced up to the reality of life. Migraine is a chronic problem. It's genetic and part of the genome. The possibility of getting migraine is always there, particularly if there are aggravating factors like stress, menstruation, barometric pressure change, skipped meals. The Boy Scout motto is, be prepared. Migraine patients need to be Eagle Scouts. The patient needs to have their medicine with them at all times. An attack can come at any time. Get a grip. Treat with a triptan at onset when early and mild. All right, so this is the end of my talk on acute therapy of migraine headache. I hope it helps all you folks. Please subscribe on there, and I'll see you again on another talk. God bless all you migraine patients.